Hi, welcome to Complicated Cases in a Box, where we present difficult and complex cases condensed into a short video and highlight the salient features of the procedure. My name is Fahim Jafary. I am an interventional cardiologist at the NHG Heart Institute at Tock Seng Hospital here in Singapore. The purpose of this is purely educational, and all patient confidentiality is completely maintained during this presentation. So let's get started with our case. Um, this is a 77-year-old gentleman um, who has diabetes and chronic kidney disease, who presented with a non-STEMI to the point that he was sick to the point that he required intubation, and eventually, after a few days, was extubated. Fortunately, the LV ejection fraction was relatively preserved at 50%, and a recent angiogram showed that he had triple vessel disease. The patient was referred appropriately for coronary artery bypass surgery, but he declined to undergo surgery after extensive discussion with the surgeons as well as with his family. Now, with that background, here's the angiogram, and you can see that the right coronary artery is small. It is a left dominant system. And you can see that the LAD is heavily calcific with a severe lesion in the mid portion as well as a severe calcific lesion in a large diagonal. At the same time, the circumflex is dominant and also quite severely diseased right at the proximal portion. And as you can see in this spider view, the anatomy is somewhat interesting in the sense that you have a large, short, but fairly disease-free left main, which then gives off the circumflex with severe disease, and the ostial LAD also has severe disease, as you can see. So we started off with wiring the LAD and circumflex using workhorse wires and attempted to perform an IVUS. And not surprisingly, the IVUS catheter failed to cross, and this was a good indication for us to proceed with rotational atherectomy. The wires were then swapped for a rotor floppy wire, and we started off with a 1.5 burr. And you can see that we required multiple runs to try to cross this mid lesion, and we're at run 4 now, run 5, run 6, 7, and pretty much 8, and at run 9 we have still not been able to cross. And at this point we decided to just take a breather. Flow in the LAD was maintained, the patient's EKG was still normal, and the patient was symptom free, and we decided to downsize the burr to a 1.25. And several runs later, run 11, 12, roundabout at run 14, the 1.25 burr managed to cross the lesion, and at this point then we upsized back to a 1.5 burr and did another couple of runs. The final total was a 17 root ablation runs. At this point, the LAD flow is still maintained, and the patient is doing well with the good EKG and normal hemodynamics, and you can see that there is good flow down the LAD. The diagonal is still, not surprisingly, quite severely diseased. We then went ahead and did an IVUS run, and this is the IVUS showing that there's a good landing zone distally, and then after that you see a lot of calcium, rings of calcium with some fractures and reverberations consistent with what you would call reasonable calcium modification with the burr. And I'll let this play out. You can see more calcium with fractures, some nodular calcium, reverberations. Again, more rings of calcium, that's the diagonal coming in. And as we come further up, there's some nodular calcium. And finally, you will see the circumflex coming in, and the ostial LAD relatively disease-free, and the left main also fairly clean. And so with this, then it was clear that there was a lot of calcium, and we had achieved some calcium modification with the rotablation burr, but we needed to now dilate this and confirm that we were able to expand the lesion. And so then we went to work on this vessel. We first started off with the diagonal because we wanted to sort of get this opened up. It was a severe lesion, and the diagonal was dilated sequentially with a 1.25, then a 1.5 balloon, and then a 2/20 drug-coated balloon. The idea was to just keep this diagonal open. It is a large size diag We felt that this was very calcified and we didn't want to complicate the procedure in a patient with chronic kidney disease and extensive coronary disease to do a bifurcation stenting over here, although certainly I'm sure some operators would. So after this, we thought that we had reasonable, although not perfect, expansion in the diagonal. Then we went to work on the LAD and we dilated with a 2.5 and then a 3.0 NC balloon and got pretty good expansion. And now we decided to go ahead and stent the LAD. So we took a 2.5 by 28 millimeter stent in the mid LAD across the diagonal, and we decided to use a jailed balloon technique to essentially keep the diagonal open. The idea is to prevent carinal shift and prevent compromise of the diagonal. So a 2.5 28 millimeter stent in the LAD, and then as you'll see at this point, a 2.0 compliant balloon goes on a second wire adjacent to the stent into the diagonal, and that is the jail balloon technique. We then go ahead and dilate the jail balloon at very low pressure, 4 atmospheres. We then deploy the stent at nominal. You can see that, I think it was 12 atmospheres. Then at this point, both balloons come down, first the stent balloon and then the jail balloon, and then both balloons are pulled out. And this is what it looked like after we did that. I'll let it play. And you can see that after the jail balloon, reasonable flow in the diagonal, although not perfect, but good enough. At this point then we did a pot in the proximal stent just at the bifurcation carina with a 3.0 balloon at high pressure. And then optimized the stent further with a 2.5 millimeter NC balloon at very high pressure. And then the jailed wire was removed, and you can see that it is pretty easy to remove a jailed wire with no problem. And then we went ahead and did an IVUS of the circumflex to see what it actually looked like. And here I've let the circumflex IVUS play. Good big vessel distally with relatively disease-free. And then as we come back to the circumflex, you can see that there is nodular calcium in the circumflex, and the wire bias is not the greatest. The wire, you can see that the IVUS catheter is in contact with the normal vessel wall rather than the nodule. And just letting it play again, you can see that the wire bias is not good. There's nodular calcium, and I must say, add that I am showing this now, although the IVUS was done initially after the circumflex, after the LAD IVUS was done. And based on this, we decided that, after we ablated the LAD, that the circumflex was not a good vessel to ablate because the wire bias is not good. And so our strategy for the circumflex was to do shockwave lithoplasty. And so we went ahead and took a 3.5 by 12 IVL. And you can see that in that area where we identified the nodules, not surprisingly, even after 80 pulses, the circumflex remains not fully expanded. We then went ahead and took a 3.5 Scoreflex cutting balloon. You can see a fair bit of recoil. And this was like at 26 atmospheres in this spider view. You can still see a waist, which is concerning, which means that stenting this may not be optimal if you just rely on this view. However, in the cranial view and an orthogonal view, you see pretty good expansion of the balloon, and therefore stenting, I think, based on this is feasible, but you have to have managed expectations. And the thing to remember is that in this particular case, you will have a stent that is likely to have a good stent area, but it will be asymmetrically expanded. In other words, will not be a nice round-shaped stent. It'll be a somewhat asymmetric D-shaped stent, which is okay as long as the stent area is good. And we did consider the option of drug-coated balloon angioplasty, but you can see that there is pretty much, pretty significant recoil. And again, I'm going to let this play one more time. You can see that, even after a ton of ballooning, even a 3.5 Scoreflex balloon at 26 atmospheres, there's quite a bit of recoil. So while drug-coated balloon would be another option here, we opted to not go that route. So then the question is, how do you stent this anatomy where you have two severe lesions at the ostial LAD, ostial circumflex, and the left main is pretty clean, and the left main is also quite short. And of course, there are multiple two-stent techniques, which include DK crush, culotte. And in this particular case, we opted for V stenting because the left main was very disease-free. And so here you can see now the stents being positioned. You can see that there is one stent in the circumflex just protruding just beyond the ostium, and another stent in the LAD protruding just beyond the ostium, with the two stents sort of meeting in the distal left main, almost meeting in the polygon of confluence. And there was a 3.5/18 there and a 3.5 stent in the LAD. And you can see that we deploy both stents simultaneously, but at low pressure. That is the key thing. You deploy at low pressure because you don't want a high pressure simultaneous deployment and end up dissecting, or even worse, rupturing the distal left main. So we deploy this at 6 atmospheres. We then deflate the balloon and then inflate each stent balloon at high pressure. So first the circumflex at high pressure and then deflated. So you can see the circumflex balloon going up and then deflated. Then the LAD balloon at high pressure and deflated. And then a final kissing balloon with both stent balloons again at low pressure, 6 or so atmospheres. And then you deflate and remove both balloons simultaneously. We then went ahead and post-dilated with in each limb a 3.5 non-compliant balloon, same length, and did the same thing, high pressure in each limb and then final kissing at low pressure, and that's shown over here. And again, the idea is to prevent any crushing of the stent if you deploy a balloon only on one limb. So high pressure in each limb and then low pressure kissing. And these are the final images that you can see, and reasonably acceptable result. You can see that the circumflex is not perfect. We expect that. That's the side of the nodule, but still not too bad. The LAD looks pretty good, and you can see the LAD pretty good. The diagonal is patent, although dissected, but these dissections almost always heal up. There is TIMI3 flow, and this is now IVUS examination of the LAD. You can see that the distal stent landing zone was great. The distal stent nicely expanded, mostly symmetrical so far, and there comes the diagonal, and then subsequent to that a bit of asymmetry, but still very well expanded. And you can see that this is now slowed down to show you the proximal extent of the stent. This is the prox LAD, and in just a second you will see the circumflex showing up here, and this is the ostial LAD with a good stent area. The stent area at the ostial LAD was 8.7 millimeters square, which is pretty good. Similar IVUS from the circumflex, and you can see distal landing zone is good. The mid circumflex well expanded, nice and circular. And then we come to the area where the nodule is, and you can see, not surprisingly, it is oval shaped or asymmetric, but yet the stent cross-sectional area is very good. It's 8.5, which is perfectly acceptable. And then as you see, as we come back to the ostial circumflex, you can see good expansion of the stent and a short segment of the stent abutting the LAD stent. So this is the ostial circumflex, 8.5 millimeters square, and that's pretty much it. So in summary then, if I was to sort of summarize things, this was a good example of a case where we had heavy calcific disease. We had to do extensive rotablation, and we had to persist with it. And sometimes it takes a lot of runs to cross lesions. And then after calcium modification with rotablation, extensive balloon dilatation. You saw the jailed balloon technique for the diagonal, where the diagonal was kept open, and the final result in the diagonal is good. There is good flow. In non-flow limiting dissection, these will always heal. And then the circumflex, which we IVUSed up front, and although I showed it later in the presentation, the circumflex has severe nodular calcium, but the wire bias was very unfavorable, where the IVUS catheter was actually hugging normal vessel wall. And the danger is that if you rotablate over here, or do orbital for that matter, orbital atherectomy, you may end up dissecting the normal vessel and even result in a perforation. We used shockwave IVL, and we got a final. And before we deployed the stent, we got good balloon expansion in orthogonal views, not perfect but good, and we were able to predict that the stent would have a good stent area, although will be asymmetric, and that's exactly what we found on IVUS. And so this also highlights the value of using imaging to direct yourself, direct a strategy as to what you're going to do. And so you saw that we did V stenting, which is not a common technique. I would say the last time I did this was 5 years ago, so it's really uncommon most of the time, because the distal left main in such a situation is rarely disease free, but in this case it was. And so V stenting was an appropriate choice over here, and we got a good final result. So ladies and gentlemen, I hope this case was educational for you, and we'll be happy to hear any thoughts and comments on this. Thank you very much.